Let's start live case session 6, Mitraclip session. My name is Jung-Sung Kim, Yonsei University Severance Hospital, Korea. My co-chair is Samir Kapadia, Cleveland Clinic, United States. In this session, wonderful case is prepared in Asa Medical Center by Dr. Do-Yoon Kang and Tae Kim. I would like to introduce 4 excellent experienced panelists, Sunsuke Kubo, Takeshi Matsumoto, Edgar Tae, and KK Young. Firstly, let's start live demonstration. Are Dr. Kang and Dr. Kim ready to get started?
Yes, welcome to TCTAP 2022 with a live case session with a Mitraclip. I'm the operator, Dr. Do-Yoon Kang, and this is my structural heart specialized fellow from Saudi Arabia, the Mohammed Go study, and Dr. Tae Kim, our imaging specialist. And today's case is the patient with the functional MR with the severe dilated cardiomyopathy. So can you please show the case slide? Yes. The patient is a 78-year-old female, and she was admitted for worsening dyspnea with a near class 3. She had been treated for DCMP for 17 years ago and treated by the heart failure specialist. And she also underwent CRT 12 years ago, but she was non-responder to the CRT. And she had worsening functional MR since 1 year ago, and it was increased to the grade 4 from 6 months ago. The heart failure specialist prescribed the oral heart failure medication, but there was no improvement in symptom. And the TR was planned for medically refractory symptomatic functional MR. She also had a history of paroxysmal AFib and underwent this cardioversion 2 years ago. And next. And she also had a diabetes, and she had height and weight is very small and very light frail woman. And the STS score for mitral valve replacement was 5.85%. And as described below, she received NOAC and beta blocker and Entresto and Lasix and spironolactone and SGLT2 inhibitor and insulin. All heart failure medication was prescribed, but the up titration was not possible because of the low blood pressure around 90 to 100. And after admission, she was infused the dopamine and norepinephrine for 1 week with the IV Lasix for volume reduction. And next. And this is the echo finding. At the TTE, LV ejection fraction was 21%, and LV end systolic diameter was 64, and LV end diastolic volume was 243. MR grade was 4 with the EROA 40, very severe MR, and there was moderate pulmonary hypertension. And after 1 week of the intense inotropics and diuretics therapy, still the MR grade was 4, but the pulmonary hypertension decreased. And TE showed coarctation failure with the leaflet tethering. And CT showed normal coronary ACT. And next. And the chest X-ray shows the cardiomegaly and CRT. And after the volume reduction, the pulmonary edema is not so severe. Next. And ECG showed the CRT paced rhythm, but wide QRS still. Next. And this is the echo finding. The TTE shows the eccentric, the functional MR with the tethering of the leaflet. Next. And next. And also TEE showed some tethering of the medial central leaflet with the severe MR. And our echo specialist, Tae Kim, will present the current status of with the TE image.
Hello, everyone. Good to see you again. This is Tae Kim from Asa Medical Center. Can you see the image?
Yes.
Yes.
Okay. The patient. This is a mid-esophageal chamber view. As you can see, severely depressed LV dysfunction and severely tethered mitral leaflet Unfortunately, the echo window is not so good. In color flow image, you can see some picture. This is by commercial view. As you can see here, the mitral valve leaflet severe tethers. Interestingly, in medial portion, more tethers compared with the lateral region. And in color flow window, you can see a multiple picture and diffuse MR jet right here. In biplane image, as I mentioned before, the tethering of both leaflet is more severe in medial region like this, but the coaptation gap is not big. Or I think just 1 millimeter. In central region, biplane imaging. In lateral region, biplane imaging, this patient has more tethered in medial region. And 3-chamber view, you can clearly see a severe MR jet, the pizza radius 8 millimeter. 2 days ago, transseptal echo imaging, we found that MR decreased slightly after aggressive diuretic therapy. We stopped the diuretics yesterday for live demonstration. Forgive our curiosity. In right upper pulmonary vein flow, you can see definite flow reversal right here. However, in right upper pulmonary vein flow pattern, no flow reversal, but diastolic dominant flow pattern. In 3D unfast view, we initially, as I mentioned before, the tethering of medial region more severe than lateral region. We planned to deploy initial clip as XTW. The mitral valve area was a 5.4 square centimeter. We initially placed the first clip right here using XTW clip. After then, we check again. The panelists will determine the next clip.
Let me summarize the patient, 78-year-old long-standing DCM with with the severe functional MR, and she was treated by the whole heart failure PO medication, but could not achieve the adequate volume reduction. And with only IV inotropes and the diuretics, we could reduce the degree of the MR. And so we planned for the Mitraclip for medically refractory symptomatic severe functional MR. Do you have any question or comment for this patient, dear panelist?
No, I think a wonderful case and great presentation. I think the imaging is also outstanding. The question that I have a little bit is before maybe we can ask the panelists if they have any questions about the medical treatment or CRTD, but I think all the medical treatment is wonderful and the CRTD is already done. So clearly a technical question is that why do you plan to use XT versus NT? So when do you use NT and when do you like to use the XT clip?
Yes, in this case, because the valve area was large enough, more than 5 square centimeter, and the coaptation, the width was wide. So we plan to clip with a larger clip to reduce the degree of the functional MR as much as possible with the one clip. And that was our plan. And I want to ask the experienced panelist more.
Yeah. So what was the length of the post leaflet? Is it enough?
Oh yeah, but
more than
15 or
15.
Right.
Can you please show the echo image of the posterior leaflet?
Okay.
Yeah.
So for the functional MR, sometimes when the coaptation is very horizontal, like this, which causes the annular dilatation.
Enough posterior leaflet length.
Yeah, posterior leaflet is long. There is not a problem. The question
no problem at all.
No problem at all. But the question is that the anterior leaflet and posterior leaflet, they connect rather than at the depth, they are meeting each other very horizontally. So when you put a large clip and pull it, sometimes you can have a little bit too much tension on the anterior leaflet.
I agree. Yeah.
So the tearing of the leaflet is possible with very large clip, especially if the lady is small. And so sometimes for the functional MR, I like to use an NTW clip rather than an XTW clip.
Yes, that was the very difficult point for the decision. And
very difficult decision point. I agree with you. And we don't have a lot of data to say which one is better. The good news here is that there are no clefts in the posterior leaflet. The posterior leaflet is, so this helps. If you put a large clip and if you have a lot of clefts, then the clefts will open up when you pull the posterior leaflet anteriorly, because that is what is likely to happen, is that the anterior leaflet will come very, very close to the posterior leaflet when you put a large clip.
So is there any other comments from the panelists for the selection of clip?
I don't have a question on the selection of a clip, but I do want to make a comment that you know, with inotropic support diuresis, general anesthesia, the MR doesn't look as terrible as the pre-procedural echo, but that is fully to be expected, and therefore sometimes can make assessment challenging when we put a clip in. And I guess we can discuss this later on, but you know, we have to think of strategies to assess the MR, you know, after the clip is placed, for example, driving up the blood pressure. But I thought that the echo imaging clearly illustrates the point that in functional MR cases, after adequate treatment, general anesthesia, it is sometimes doesn't look too bad on during the procedure itself. Thank you.
Yeah.
But still, it is fairly significant MR considering all this, and there is already an opening. The coaptation is not good. So this is a patient that definitely needs something for the mitral valve. So it's a good choice of a patient for this, in almost a little bit too sick and a little bit too far advanced compared to what we like to see these patients.
Yes, this patient has the ejection fraction is 21%, and the LV end systole diameter was 65, and he at the margin of the FDA approval criteria of the Mitraclip for functional MR. If the patient has the lower ejection fraction, like 18, 70%, and how do you do? Do you still apply the clip for the functional MR or just treat medically? I
find that clip is super safe for these purposes, and it is very rare to run into trouble with LV dysfunction, even though the afterload increases. It is not common to see severe problems during the clipping. Very rarely we have to put a balloon pump, but that is not common at all, even with very low ejection fraction. So it is a good point. But I think, again, the inotropes, very important part is also RV function. So what is your RV function, and the RA pressure is going to be important, because if there is a lot of TR or RV dysfunction, then after your clip, you may have to close the septum. So these are important questions. But PA pressure came down with your treatment. So that's, again, a good thing that you admitted the patient and treated them very aggressively.
Yeah. Luckily, the patient had a normal RV contractility with a low RV pressure. Okay.
But this is a very good indication for the Mitraclip. Just
Okay.
Okay.
Go ahead. Yeah.
So we begin the procedure. As you can see in the fluoroscopy image, can you please show the fluoroscopy image? Okay. There are 3 lines, very crowded, the SVC and RA. So we already did the septal puncture with the RAO view and approaches the posterior next. And then with the echo guidance,
we did see echo images simultaneously.
We did the septal puncture with the SL sheath with a routine BB needle.
Initial target was 4.3 centimeter from the annulus, but the real puncture site was slightly lower than expected. But this patient that is functional MR, we decided to go ahead in this puncture site. Nowadays we are already checking 3D images from the catheter to annulus relationship between like this. As you can see here, this is the catheter and commissure line, slightly posterior from the commissure point. I think the best position for mitral clip.
Yeah, we did we could achieve the more about 41 millimeter height and the posterior position with the second puncture, and that view of the unfounded view was really helpful to get the good puncture position. And we introduced the steerable guiding catheter and prepare the XTW clip. Yeah, as discussed before. Yeah, I will move on. Yeah.
Slightly withdraw the catheter before the clip get in.
And I think it is the transseptal puncture was very good because you also avoided the pacemaker wires.
Oh,
Yeah.
So this is also
very
important.
Have to be cautious during the puncture.
Yeah, it was
Right.
somewhat very difficult. And actually, at the first, there was some.
I saw that. Yeah.
Some difficulty to avoid the interaction between
Atrial wires.
yeah.
But usual recommended puncture height is 4.5 to 50 centimeter above the coaptation of the leaflet, is it? Yeah, because it's also target the site is a more medial
the
side.
clip get in.
Yeah. And before just after septal puncture, we measured the airway pressure. Oh, sorry, that's seen in this view, but it was about 14 in peak and 9 in medial. There was a small V wave. Maybe the V wave is not prominent because Dr. Kim did the aggressive volume reduction before the procedure. And now we are here. I'm introducing the clip. Can you please show the echo? Okay.
Yeah.
Okay, we are now in the saddle position. Let's move to the M dive. Can you please show the echo?
Yeah.
Okay, we're going.
Okay, let's move to bipolar animation.
Okay.
Okay.
Our first target was the mediocentral lesion with the coaptation gap.
So in your case, you don't hi KK here.
Yeah,
in your
hi.
case, you don't use a pigtail, right? To
Oh
keep.
yes. I want to ask the panelists about your experience. Actually, I also tried to use the pigtail for the continuous pressure monitoring, but there was some severe oozing, blood oozing in the femoral side. So now
Yeah,
I'm not
same.
routinely using the
I also
pigtail.
don't.
How about that?
Yeah, I personally don't use it from the same side, but I just stick a 5 French sheath underneath.
Yeah.
And just use that because when you put it in the same side, there is sometimes oozing.
Yeah.
From the if you use 4 French, it's less oozing, but still it is not easy to control the bleeding. So I just put a 5 French sheath below the sheath if you are really interested, because this kind of patients who have already low LA pressure, it is not so important to put a pigtail.
So we are more depending on the pulmonary artery, the reversal flow, pulmonary venous reversal flow. As I'm moving to the mitral valve. Okay.
Oh, okay. Anterior posterior position good.
How about the trajectory?
Okay.
Is it
the site is
too medial?
Oh yeah, no, I don't think so. Okay. Okay, trajectory is slightly L dive.
L dive, you mean? Okay.
Yeah, I think it is doing a little bit lateral to medial dive on fluoroscopy.
Yeah.
Looks good.
How about this angle?
Yeah, looks good.
Or move a little bit posterior,
Please move more centrally.
more centrally.
Do you use the 3D MPRs?
We are not now using the 3D MPR. Is it available, Dr. Kim?
Oh, yeah, sure.
Because it's an X8 probe, right? It's a beautiful.
Oh, beautiful image. Let's see.
Yeah, beautiful.
How about this trajectory?
Looks good.
Or maybe M dive or
Slightly M dive.
slight M dive?
I think the MPR image is very good for live demonstration.
Yeah. Okay, I will move a little bit more. Yeah, but actually we are not routinely using the MPR for the procedure. We are our routine view is the X plane with the short axis and three chamber long axis view. And
Okay,
how about
biplane?
yeah, please. Okay. Can you please show the target zone?
Okay, let's
with
take a
the
3D alpha CPU.
Color image. Yeah.
I think the check color.
Mm-hmm.
You can move more medially from
More medially,
here.
you
Yeah,
mean?
in 3D alpha view.
Yes. I moved a little bit. Yes, there are some artifact of the image because of there are so many lines and CRT leads that makes the image blur.
The position looks good.
Yeah.
Let's check 3D again.
Okay.
I think the 1 hour is longer than expected for this case.
I will open the clip 180 degree and let's check the
yeah, okay. The
angle.
position looks good. I can please. Let's check gripper function.
Both gripper is working well, and the gripper with the black one is the anterior one,
and the
posterior one
close
also
the clip.
works well. Yeah, and can you please show
So
the
3D alpha again?
Yeah.
Okay. Slightly clockwise rotation.
More clockwise?
And counterclockwise.
No,
Okay,
counterclockwise.
Counterclockwise. And
how about
first move posteriorly? Yeah, using guidance. Okay. Looks good.
Do you think there's the M naught is too much?
Yeah,
I agree.
I think it's too much.
Yeah, M naught is too much.
That's too much. Yeah, and I will. Move. Okay. Yeah. Less M. Can you please show the echo? Okay.
Oh, where is the clip? Two more.
Less M and move medially. That would be a better angle.
Okay.
Yeah.
Color please.
Just pull back the whole thing. Yeah.
Okay.
Okay.
And then we'll open and we'll check the perpendicular view again. No,
I think it moved little laterally.
So yeah. 3D 2D를 다시 한번 보여주시겠어요? biplane을. Yeah. Can you please show the biplane again? Let's check everything again. The angle is not so good, I think. Yeah. Okay. Let's begin with the trajectory again. it goes a little bit centrally. Yeah. How about this angle?
Okay, try
I
to
like
is
this
good,
angle.
but
Yeah.
you have to move more
And we'll
medially.
open.
Yeah, like this. Okay.
Okay.
Pressing
Can you
good.
please see the
3D unpass.
yeah 3D function view?
Okay.
Okay. Was some rotated, and I will rotate clockwise to make perpendicular.
Oh, the two much.
No, it was good. I
Yeah.
think.
Yeah, posture diagram.
Okay.
Press rotate counterclock.
A bit counterclock. Okay. How do you like it? More?
More.
Little more.
counterclock.
More.
A little
Yeah.
more.
Or little more.
Oh.
Okay, looks good. Do you agree?
Yeah, I agree.
Okay. Okay.
Okay.
Let's move on.
Plan again.
And I
Okay,
will
cross
dive.
clip.
Yeah.
Let's get in to agree.
And open. Sometimes, especially for the XTW, it rotates after getting into the LV. How do you overcome?
조금 더 깊이지만, 예, 너무
It was fully rotated.
Fully rotated. Yeah, I
Yeah.
think it is wrong. Yeah.
Yeah,
Yeah,
So just check
90,
yeah,
90 degree
yeah.
rotated. Yeah.
Check the 3D.
Yeah.
Yeah, check 3D.
3D again.
Yeah, the flora is helpful in this case because you can see it rotate.
Yeah.
But it is a problem though, although the system
not-
is supposed not to rotate too much. Yeah.
But it is
Clockwise
not,
rotation press.
not too bad, but just little clockwise maybe.
Yeah. A little bit. Very
Slightly seems to
gently.
be M dive.
Gently.
Okay, looks good.
Okay.
Yeah.
Yeah.
How about the position?
Yeah, too slightly deeper than usual.
Yeah.
Oh, it looks good.
Is it good position for target leaflet or move
Check a
more
left
medially?
color.
Yeah.
Yeah, it's the best position according to the color flow.
Yeah. And can you please show again the 3D unfunction
Oh,
view?
sure.
It looks a little bit rotated.
Fluoroscopical looks good.
Yeah.
Do you agree
Yeah,
with this?
slight,
Yeah.
slight counterclock.
Yeah.
Yeah, slight counterclock press.
Okay.
Okay, looks
Now
good.
it looks more
Okay, let's
better.
move to biplane again. Okay. Move more medially.
Medially.
And maybe make the long axis view a little bit more steeper, huh?
Yeah.
So if you make it instead of 60 and 180, maybe 40 and 160.
40 and 160.
Making the,
Maybe better,
the
yeah.
long axis
Oh, okay, I
Yeah.
agree.
will be better. Yeah.
Or you can just turn the long axis.
Yeah. The axis is
Yeah,
not
see now you
correct.
see a little
Yeah.
bit better, yeah.
Okay.
Okay, best position
Very
for.
good advice.
Let's check 3D again.
Yeah, please. You like it?
Pretty good, yeah. Slightly
Yeah,
in the middle.
a slightly
good.
clockwise.
Okay.
Okay.
Yeah, I think you need to clock a little bit, yeah.
Yeah,
A
or a little bit
bit.
clockwise.
Okay.
That's good,
Okay.
that's good, that's good. Don't
Yeah.
clock.
That's it.
Let's move to the optionally. And can you please show the leaflet? Okay.
Yeah, I'm trying.
The image artifact is very severe.
Yeah.
And see you are,
Oh yeah,
You
how
are-
about this?
it's very good, but the cord is not
Okay.
letting you go underneath the posterior leaflet. You see how the cord, so go a little bit further, yeah.
I think.
Okay.
Now better, yeah. I saw a little bit better.
Yeah, I missed the. Okay. Oh, okay.
Do you think we are too medial?
Yeah, slightly move to medial.
Yeah, I think so
According to
too.
the image, yeah, we have to move more
Okay.
centrally.
I will move more centrally a
Yeah.
little bit.
The challenge is that when the system is in the LV already, when you push the guide in.
Oh yeah, better than
the-
before. Best position, I think.
Yeah, but the risk is, of course, the whole guide translates into the LA a bit, and there's a curve. But I think here looks not too bad. I just
Yeah, I
always
think
worry
that
a
let's
bit about it.
try to grasp here.
How about the echo, the color image? Is it good?
Okay.
Or move more centrally?
Yeah, more centrally. Slightly more centrally.
Okay.
You are located just the margin of the picture. Okay.
Okay. How about the?
Okay, let's
anterior
try
reflex? Okay.
at the side.
Your clip is fairly everted, huh? So just
Yeah,
close
too
it.
much open. Yeah.
Okay, I'm closing.
Okay.
Can you see the anterior posterior
Posterior looks
reflex?
a bit loose still.
Like this. Yeah, how about this image?
Yeah, okay. 잡아볼까요?
네.
네.
Anterior is on. You
Can
have
you see the posterior?
put the posterior.
Okay.
Posterior looks off still.
Posterior again.
Better than before, but you have to more.
Posterior reflex is not well visualized. I'll try again.
Yeah. This is good for posterior grasping.
How about now?
Not sufficient.
Anterior reflex is not sufficient. Okay.
Was there any plus on the guide or something like that?
Grip down, please. Grip
Yeah.
up.
Grip down, please.
Grip down.
Anterior is good, but the posterior. Oh yeah, posterior is better than before.
Can you
I
see
think.
the posterior?
Yeah, better than
Yeah.
before. Let's close the clip slightly at 60 degree.
Can you please check the color?
Okay. Let's check a 3D position.
Yeah. I think the clip is a little bit rotated.
Yeah, counterclockwise. Yeah.
You know, I still think there's something. The guide is, how do I put it, hooked a little bit, and that gives you a bit of bias. I don't know how to describe it.
다시 한번.
And it looks like a little bit medial dive.
Yeah, it still looks the medial dive.
I think also the clip is anterior dive. So
뭐 미디얼로 좀 더 가야 되겠는데.
Okay.
Please move the clip more medially.
다 돌아갔거든요. It was rotated. 그 클립이
Yeah, let's check
rotated.
the.
Yeah.
I think too much rotation inside, so be careful.
Yeah.
Okay.
You know. 잠깐, let's make 3D image again.
Yeah, making a good image is very, very difficult.
Okay, it looks good.
How about this medial rotation, counterclockwise? Is
No,
it
it's good. It's good.
Yeah,
It's
good.
Okay.
It seems to slight. I think there.
Slightly.
Yeah, it
Nice.
seems to be M dive in this view.
Okay.
Yeah, it seems to be. Do you want to be more central?
Yeah, but this position is good.
It's
Yeah,
good,
in
huh?
this view, but in 2D, you have to be more medial in this view. That's good.
Very
There's a
difficult.
discrepancy
To the
between
different
3D and
side of
2D
view.
images, but we put the problem deeper than before. The position will be changed. Yeah, looks good. The position in this view.
color 한번.
Yeah.
Can you please check color? Yeah.
Yeah. That's
Okay.
the.
That here would be the
Yeah,
name of the
yeah.
TISA.
TISA.
And
Let's
I will
grasp
catch
here.
here. Gripper. Oh, not now. Okay, gripper down.
Yep. Okay. The anterior posterior
Yeah. How about
position
this
is good.
position?
Yeah. Let's close the clip.
Yeah.
At,
It was 60-degree closed.
Yeah, the portion is better than before, I think. Yeah.
And can you please show the
3D?
3D and the safety of the clip, stability, the position. Okay.
Oh, it looks good. Okay. Mm-hmm.
It was just 60-degree closed.
Full course,
And
please.
shall we?
I think we can finish it with just one clip.
Okay. It was fully closed.
Better than expected.
Yeah.
Oh, very nice.
Very nice.
Yeah.
It looks good.
It's still difficult for us to predict the best result after
Let's
clipping.
take the insertion of the clip. Can you close the clip more?
Yes, it was
Try again.
fully closed.
Yeah, this is XTW.
Yeah.
Yeah, you should release the tension of the clip. So push the clip
Chris,
to the.
can you release the tension slightly?
Okay. Tension was released
Yeah,
a little bit.
Yeah, now
looks good.
Now it's better. Yes.
Yeah.
Let's take a color.
Oh, it looks good.
Very nice. Yeah.
Very nice.
Can you please show the pressure gradient or pulmonary venous flow
Okay,
reversal?
let's take a left upper pulmonary vein. Previously,
Dr. Kim loves the pulmonary venous flow reversal. We always depend on the result of the pulmonary vein.
Oh.
Oh, it's not a good sign.
Yeah, the systolic flow appeared again.
Yeah.
Like this. I think the reversal improved. Let's take a left upper pulmonary vein.
Okay.
The systolic dominance.
Do you check the
four
this is
pulmonary
good.
veins?
Yeah, the fully normalized left
Yeah.
pulmonary vein. The systolic dominance appears. Okay.
How many veins do you check for the flow of venous reversal?
Yeah, usually in the procedure, I usually check left upper, right upper.
Left upper and right upper.
Yeah. But in patients with very eccentric MR, we have checked 4 pulmonary veins always.
Yeah. Okay.
But this is based on the functional MR.
Yeah.
As 2 veins are enough. Yeah, fully normalized pulmonary vein. So, okay. Let's take the mean pressure gradient.
Yeah.
1 hour is too much.
And sometimes when when we check the echo before deploying the clip, the result is excellent. But sometimes after deploying the clip, the result differs. Then how can you predict and prevent such kind of event? Do you have any tips and tricks?
That's a good question because when you are having some tension on the clip, there is no easy way to analyze this. One thing to check is that if you do
2 millimercury.
Yeah, if you check the morphology of the valve from the LV side, sometimes that makes you on the 3D on the LV side, you can see that how the clip is tugging it or not. So because it will fall down, right? When you let go, the valve will go ventricular.
Yeah.
And so that can help you to predict a little bit. More difficult for the degenerative MR than functional, because in functional it's unlikely that it's going to be much worse.
Yeah.
And here it looks nice that the valve is coming up all together.
Yeah. Okay. And
I think the perpendicularity is very important to
Yeah, exactly.
before releasing the device. So sometimes I think that the perpendicularity is not so good. Then when before releasing the device, the MR is not that severe, but sometimes MR grade is increased after releasing the device. The other thing is recently I have a question to the panelists or other Samir, because recently I experienced with the XT system rather than NT system. How much do I tighten the device? Because sometimes we can have some experience intra clip, MR jet after releasing the device. So I'm not sure that kind of situation. So do you have any experience for that?
Yeah, I agree with you that when sometimes the clip doesn't tighten and it leaks inside because it opens up, or if you tighten it too much, you can tear the leaflet. So both sides we have encountered. Again, so the key with all these large clips is to be very careful about rotation of the. We use 3D MPR routinely for all the deployments. So this sometimes helps to prevent the rotation, because rotation is the key.
Yeah, I agree. Personally, I fully close both NTW or XTW, but when we close XTW, we very carefully slowly close it, and also check arm orientation again and again before fully close the leaflet.
Right.
Yeah.
I think that's the most important message, if there is one, to say that the arm orientation has to be checked. So
Sunsuke, any comments? Yeah.
Yeah, I also I always fully close the XCW, but I check the tip of the arm. So when we close the XCW, the tip of arm to going toward to the left atrium. So if when we see the tip of the clip up to the left atrium, so we release the tension. The clip to the LP. Yeah, always.
Good point. Yeah, so you want to keep it at the coaptation line.
Yes.
Right. I agree. And especially with the second clip, because when you're going to put, here, we don't need a second clip, but if you're going to put a second clip, if you pull it up too high and try to close it, it will tear again the leaflet. So you want to keep it at the level of the prior clip. Fluoroscopically, it also helps.
Can I check the intercommissural view?
Okay.
You know, I'm just want to be sure about the appearance. You know, if you look at this intercommissural view,
in 3D or
this one is fine. Is there any worry about the medial side? You know, there's a bit of asymmetry there. How do you make out that you know? You know what I'm saying? Normally you like to see the seagulls, yeah?
Yeah.
But it looks good in my opinion, because I think that every valve is a little different. So depending on the angle you're cutting, sometimes you can see it.
I agree that the reduction of the MR is sufficient, and the pressure gradient is only 2, and Dr. Kim checked for 10 minutes for the stability of the valve, and he agreed to deploy the valve. So I will deploy the valve.
Everybody agreed to deploy the valve?
I checked the stability and safety.
Excellent.
And we'll remove.
All panelists that agree.
Okay, deploy. Okay, 8 times counterclockwise. 1, 2, 3, 4, 5, 6, 7, 8. Let's see the result. Okay. Removed. I deployed the clip.
That's usually the most scary part.
Show the result. Can you please review the echo?
Yeah,
Very
slightly
nice.
increase MR.
But you know,
That's
this
very
is
nice.
expected, but it's
Yeah.
still very good, I think.
So in this case, would you drive up the blood pressure with a
Now blood
vaso?
pressure is 104 to 60. Okay.
But this is the patient lives there, right? Patient's blood pressure, as I understand before, was 110
Yeah.
or 100. So it is not that different.
Yeah, that's
Yeah,
right.
Let's take
this,
pulmonary vein flow again.
but on the other hand, Samir, this patient, you know, is optimized for the procedure. I mean, wouldn't you consider driving up the blood pressure of a vasoconstrictor?
Yeah, the superior.
But what will you do is the question.
Maintained after deploy.
So I agree with you that what I like to do, say in the 3D, if the valve is closing, all the coaptations are coming together. That is more important. Yeah, we will see that, but that is more important than driving up the blood pressure, because I think and sometimes we do increase the blood pressure to see if you have a strategy, because here it is leaking throughout.
Well, the question I have is that, you know, if the MR looks worse, say on the lateral side, maybe you want to put a second clip if the gradient allows.
Yeah.
So that's the reason why I thought that maybe we should drive up the pressure, just to check.
Yeah, let's see. The blood pressure is 110 to 60, and you can see the airway pressure. The peak is the 24, the mean 14, and small V wave.
Can you show us from the ventricular side too? Yeah, I like the valve. You can try to increase the blood pressure, but it won't leak.
After increasing blood pressure, I think there's 112 systolic blood pressure. 100.
조금만 올려주시겠어요?
120에서 130 정도만 조금.
Yeah, we increase the blood pressure, and let's see what happens.
How was the initial blood pressure for this patient?
Initial blood pressure was 100.
But increase in systolic blood pressure by 10 millimeters after one clip deployment.
I think this is good.
I think we can place the clip both sides. Maybe
I think that the regular MR is coming from the medial to the clip and the clip itself. So I think I don't like to put the second clip.
I'm actually okay with this. I mean, you know, the stress test reassures. But you know, usually for such cases, I kind of ask myself, will a second clip necessarily help stabilize, and whether it help the MR? I don't know. I'm okay with this, but I must say I'm beginning to wonder whether I should put a second clip, and I frankly struggle with this a lot.
For functional MR, this is a very common question that, you know, next day when you see the patients, you know, the MR looks a little bit worse.
Yeah.
And, you know, it bothers you that whether that is, that you should have put another clip or not. So this is not uncommon. On the other hand, you always have a chance to put a second clip later.
Yeah.
Because which side, medial side or lateral side? Let's vote about this.
Okay.
Both sides are leaking. Yeah, exactly. So they are coming together from both sides.
Then what would be the best treatment for this patient? More medical treatment with a decreased MR?
I think that we can place
one other clip.
medial side, because after MR, if the patient, the progression of MR, the medial side of coaptation gap will increase afterwards. I think that we have to put another clip medial side.
At the medial side.
Lateral side.
Lateral side. You mean lateral side?
Yeah. More central. Yeah.
There are some debate.
Any comments?
Panelists
Yeah,
want
but
to
I
start.
think in the future direction, they might increase more in central side. I think we have to second clip in.
Yeah. Okay.
About
I am not so
clip,
sure
NT or
personally.
NTW.
So jet looks good worse, but when we look at the pizza, it's very small. I think this jet is significant or not.
I personally would not put another clip. I would say that just see how patient does. I don't know economically and socially what is the situation to say that you can do it as a stage procedure, the second clip, or not.
Oh,
but that is a consideration, especially if you are going to leave the septum open. That will also help the these HAPREF patients. So that both of them with normal RV function. So
why don't you check pulmonary vein flow again?
Okay. Let's check
the problem is that the second procedure.
If it is not systemic dominant, we don't need to put second clip.
Yeah.
Okay, let's check.
So I think it's very important point for the ASD, iatrogenic ASD.
It's normal.
Aortic decompression after septal puncture.
Yeah.
The left pulmonary flow looks normal like this, but let's check right pulmonary vein.
Yeah, I agree with Sami and Takashi. The lateral jet is not so large, and so you can also the second session after the this session. So
right pulmonary vein looks normal.
Yeah,
like this.
I think this case is very good, to illustrate the challenges as proceduralists when we do a case. We see the MR, we want to fix it. I would say that most times I will leave this, but before I leave it, I would carefully interrogate the valve to make sure it's stable, because, we wait long enough, sometimes the valve starts to tear. So I'm always very paranoid. I think deserves to make sure that leaflet insertion and the valve is stable. If there is any question of stability, I would put it in a second clip, but by itself, the pulmonary vein flow is very reassuring. But I think this is very illustrative of the challenges we face in dealing with functional MR, like this case. So very nice illustration, very nice result as well.
No, I agree. I completely agree. Now, the second question is that I know that she had 2 cardioversions in the past.
Yeah.
And it looks like that she's in AFib. Yeah. So there is if you wanted to cardiovert, this is another good thing to consider, because with the reduction in the MR, you might be able to cardiovert her, and that may improve a little bit of this MR also, because some of this MR could be because of the atrial non-function.
You mean we have to put the second clip right now?
No,
the all panelists want to stop here.
No, you want it. You do whatever you think is the best.
Please, just me.
I think we all agree that we should stop.
Put the second clip.
I think we all agree we should maybe just not put a second clip. But the only recommendation I have is that interrogate the valve very carefully to make sure there's no tear. Because the MR worsens slightly, so I just want to make sure there's no tear. But if it looks good and there is pulmonary systolic vein predominance, I would prefer to leave it as well.
Yeah, I think it's a good idea to leave it. But if you look at the X-plane, I think just on the when you were sweeping to the middle and lateral aspect, you can actually see that the posterior leaflet is probably we didn't catch as much tissue as the anterior. So I think that is probably the mechanism of the regurgitation, but I think the results is good enough. I think there's all these veins are working well, and I think this is because the posterior leaflet was the predominantly restricted leaflet. You could see when you pan across, we caught more anterior and a little bit less of the posterior leaflet. I think that was probably the mechanism for this regurgitation.
Yeah, I agree. Over to you.
Okay.
Yeah, and then Dr. Kim also agreed to stop the procedure here.
I changed my mind.
There's some jet in the echo, but the pulmonary venous flow reversal is well recovered, and we'll treat medically again, and let's see how the patient improved. And can you please comment on the final result of the procedure?
In my opinion, it is outstanding. The result is outstanding. The choice of clip and everything worked out, and you demonstrated very nicely that how, take your time and try to orient the clip right and make sure that the leaflets are properly inserted. Normally, again, one different thing that we do is to do 3D MPR as a routine, so you don't have to go to 3D and 2D. And that at least has changed our way of doing things in last couple of years. So this is something that, again, it is a personal choice and preference that how you do it, but that really helps considerably. But the result is excellent. And I personally think that sometimes doing too much makes things worse with each iterations. Every time you try to do something, especially in functional MR, you have to be very, very careful, because you can tangle with the clips. You can make this MR much, much worse when you try to fix this. So this was outstanding result. And this illustrates very clearly that how complicated is this decision-making and the process, and how little data we have to say that what exact clip, what exact place, when do you stop, what are the different methods, is pulmonary vein, LA pressure, cardiac output, all of those things people have used, and which one is better than the other. We don't have clear data, but we face this day in and day out. Every time we do a clip, this is a common question. So very well done.
Yeah, I think this case is a very educational case, because this all criteria is adapted to the co-op criteria: ejection fraction 20-50, and LV systolic dimension less than 70, and pulmonary systolic pressure is less than 70 millimeter mercury, and also did medical therapy. So I think that this is a quite good indication for the Mitraclip, and well done. So I think it's a very educational and informative live case. Yeah.
A great result, great technique, and I think excellent discussion. Well done.
Congrats.
A wonderful job. Yeah.
Thank you so much. Yeah.
Thank you.
Thank you.
Yeah.
Thank you.
Yeah, thank you to all speakers and panel audience and who participated in this live case. Thank you.
Very well done. Thank you. How do you close the groin? Because we have a few seconds left. So do you put a figure of 8 or you put per close?
8. Yeah. Figure of 8 stitch.
Figure of 8 stitch. That's what, I think most people do. Wonderful. Thank you. Okay.
Thank you. Good to see all of you.
Bye-bye.
Okay,
bye.
bye.
Bye. Thank you.